episode of OncLive, a breast cancer talk, the nursing perspective on HER2 targeted agents in breast cancer. I'm your host, Madeleine Kuiper. I am a nurse practitioner at UCLA Santa Monica Hematology Oncology here in Los Angeles, California. And joining me today in this discussion are my colleagues who are all experts in oncology nursing. I'd like to first introduce Loida Braithwaite, nurse practitioner from University of Wisconsin, Carbone Cancer Center in Madison, Wisconsin. I'd like to introduce Susan Hayes, who is a nurse practitioner from Washington University Siteman Cancer Center in St. Louis, Missouri. And also Elahi Saleh, who is a nurse practitioner from Dana-Farber Cancer Institute in Boston, Massachusetts. Today, we are going to navigate the evolving treatment landscape for patients with HER2 positive breast cancer. We will focus on the integral role of nurses in education and care of these patients and on the practical management of adverse events associated with new treatments. So let's get started on our first topic. What I'd like to do is sort of discuss the historic perspective on the treatment of HER2 breast cancer. A variety of our panel that we have here today, we have varying years of experience, and maybe this is giving things away, but I have been an oncology nurse for 30 years. So I happen to remember the clinical trials, and this was back when I was in Australia, of HER2, particularly trastuzumab clinical trials. And as we know, trastuzumab was FDA approved in 1998. And as we've progressed on with our new data and clinical trials, is we've seen the introduction of a variety of different other HER2 targeting therapies. So we've had a very, extensive history here. I have to definitely say, obviously, also having worked with Dr. Dennis Slayman as one of my physicians, is the change in how we treat these patients. And this has continued to progress on. We now have a variety of therapies that we can use not only in the early breast cancer setting, so neoadjuvant prior to surgery and then after surgery, and also in the metastatic setting, which we will also address a little later. I have to say NCCN guidelines are a fabulous way to understand these options that we have available and guidelines on how and when to use these products. Being from the West Coast, obviously part of my perspective when I use these is we negate using an anthracycline, and you may hear some of my colleagues who most probably maybe routinely use an anthracycline. So these are all interesting points of view for us. What we'll do is let's move on to our next area of discussion, which is looking at the issues surrounding the administration of dual HER2 targeted therapy, particularly in the neoadjuvant and adjuvant setting, and the need for convenient and effective approaches. So Susan, would you like to tell us how your institution meets these requirements?
As far as how often we're meeting to treat?
Yeah, yes, so please could you talk about, how do you manage your patients that are in the neoadjuvant adjuvant setting? How often do you see them? Do you do education prior to starting treatment with your patients?
Yes.
And what tends to be the issues that continue on? Obviously adherence to therapy, but particularly also at the moment in this current times of COVID-19 is how is that impacting your patients' treatments?
Yes, I kind of want to address the adherence to therapy in both settings, neoadjuvant, adjuvant, metastatic. The barriers placed by COVID have been a difficult one. We're in an area where there are socioeconomic, demographic, even racial disparities that can impact the patient's ability to even get to the clinic. And so that has been an impact on some of our abilities to keep them on a regular regimen. But first and foremost, I think it's just identifying the barriers that keep them away: lack of knowledge, anxiety, transportation issues, all of those things that play into their ability to even get to the clinic.
does that then cause problems where you're seeing patients having more aggressive or larger disease when they present to you?
We've had people that have delayed therapies, and unfortunately, at the height of our pandemic in St. Louis, we had where we were not doing smaller breast tumor cases. Those patients were put on hold, and a determination had to be made whether or not to continue therapy or, wait. So, yes, I think it has impacted outcomes to a certain extent.
Okay. Elahi, have you anything to add to that about your experiences during this current time?
Sure. At Dana-Farber, we do have pathways, and it's for every disease, and we do have it for breast oncology patients. And during the pathways, it's a combination of the NCCN guidelines and the new practices and new research focused on patient care. With the COVID, we did have to change a little bit of aspect of how we treat our breast cancer patients. And we communicate that actually with everybody, and it's on our internet. We tend to use a lot of patients who were able to get sub-Q injections for Herceptin rather than bringing them and having an IV infusion with longer duration. As per how do we treat the adjuvant and neoadjuvant setting in our patients, at Dana-Farber, we mostly use anthracycline-based chemotherapies unless there is a contraindicated. So mostly our regimens depends on the staging of the cancer and node positivity. It depends from the THP component versus a C-THP or TCHP in regards to anthracycline sensitivity.
Okay, thank you for that. It's always nice to hear another institution's perspective. Let's move on now to how do we counsel our patients on the common adverse reactions or events that are associated with pertuzumab and trastuzumab. Obviously, there are a variety, and usually these are naive patients. So how do we ensure that they are knowing how to handle a lot of these AEs? Loida, would you like to give us your perspective, please?
Thank you very much. So I think education is very important for our patients. At our institution, whenever we are going to start a patient, either a neoadjuvant or adjuvant treatment, or perhaps patient with metastatic disease as well, we make sure we set up time with a nurse educator so the patients can have that one-on-one time to go through the information. We provide written material and a lot of follow-up, because we anticipate that patients are not going to be likely to grasp onto all the information that entails with chemotherapy treatment and with anti-HER2 treatment as well. So to make sure that they have preparation beforehand in the education, it's likely more to be effective. We anticipate that session happening usually about a week or two prior to the infusion, the initial infusion. So I think we do a combination of phone calls, one-on-one teaching. Well, prior to COVID, it was a one-on-one teaching, but we still do one-on-one, but in alternative ways, right? So, and make sure there are any last questions to be answered, prior to, and make sure that we make ourselves very accessible to them too, because I think that's a big factor when patients are going to start treatment, is this uncertainty of how do I do if I need to contact. So I think that reassurance of this is your education, but this is also the human factor next to it. It provides a lot of that pathway for patients to be able to access to us.
And what would you say is some of the key points, or some of the key, I should say, adverse events that you tend to cover with your patients in your teaching? Do you have
Absolutely. So I think the first point that we make sure it's teach about the potential for the cardiotoxicities that any of the anti-HER2 treatments, can carry on with it, and to make sure that the patient help us with any early identification of symptoms at home, right? Especially as I share with Elahi, our institution at UW Carbone Cancer Center, we are heavily anthracycline-based chemotherapy regimens unless there's contraindication. So a lot of our patients that are going to be receiving anti-HER2 treatment also have had, you know, a doxorubicin-based chemotherapy as well. So we make sure patients know about the cardiotoxicity that can come with anti-HER2 treatments, also fatigue, you know, nail changes, which is something that we don't address or we tend to overthink, but it's something that it's very common and patients can become quite affected and distressed. So that among the, you know, other well-known symptoms that can cause, you know, alopecia and so forth, not again as frequent, but it's still, we see it quite a bit of hair thinning. So we make sure that we hit those points for patients and the fatigue among those as well.
Yes, I think that's really key. Obviously, unfortunately, patients come into therapy with pre-existing notions that are usually set up, unfortunately, by the media and are not always the correct or the things that patients really need to be concerned about, because we have ways to ways to manage a lot of these side effects so that they can tolerate their therapy, so that they can continue their regular lifestyle. And so I think that's a really key point on what we spend a lot of our time on. And not, like you say, not necessarily just pre-treatment, but as we go along and as we're actually helping them to learn as well. So thank you very much. As you alluded to, we talk about cardiac toxicities. Alehi, I'd like you to further expand on what you were talking about earlier, particularly, you know, when we are looking at the potential cardiac toxicity long-term from these HER2 targeting therapies and the use of an anthracycline, particularly in the early breast setting. Could you tell us how you manage your patients and how you monitor them?
Sure. Our protocol is based on at the initial treatment prior to initiating any anthracycline or HER2-directed therapy. We obtain an echocardiogram to evaluate the ejection fraction of every patient. For adjuvant setting patients, they will continue on it every 3 months with echocardiograms. In our metastatic population, it depends, but mostly it fluctuates between 6 months to 12 months period. We are lucky in our institution. We do have an oncocardiologist program that we tend to refer patients who, whether they come in with a cardiac dysfunction to begin with, whether there were lymphoma patients who had total body irradiation, or whether patients who actually will have a lower ejection fraction due to our treatment. And most of the time, they are seen by these providers urgently, and they quite do away. As we all know, cardiac toxicity most of the time is reversible. So with some beta blocker and ACE inhibitor and holding a treatment for even a course of 3 weeks period can and reevaluate patient can start on anti-HER2 directed therapy.
That's great. I have to say, I rarely in my setting, in the early setting, do I see a lot of issues with patients who develop an LVEF decline, unless they're a patient who's coming in with an existing comorbidity. And I have to acknowledge with you, I am so grateful and thankful that now I have oncology cardiologists to be able to refer to. I mean, it makes a huge difference. Unfortunately, not everybody has that access, but you know, we have to keep pushing for that in our practices. So thank you very much.